So good afternoon, and thank you very much for the kind invitation. Thank you to the ADR-AC team that organized it very well. Thank you, Oliver, for introducing. And so we have a very nice collaboration from our division of allergy at the University of Basel. So we very often send serum for drug allergy, but also for chronic urticaria analysis to the ADR-AC and get really nice results. And I also learned that I think we are celebrating something today. I think there is a nice birthday of yours, Werner, so congratulations. And I hope we'll have the chance later on to celebrate even more. So let's look into new treatments. And Sabine Altrichter already introduced you to the classification of urticaria. So in the current classification, the two types of chronic urticaria are differentiated. So at one point we say it's spontaneous and the other is inducible. Even though many of the patients with the so-called spontaneous urticaria have autoimmune urticaria as well. And here you see the classification in even more details. And in this slide, you also see that there is an overlap. Very often, patients with chronic spontaneous urticaria, they also have inducible urticaria. And the other way around. If you have somebody with inducible urticaria and you ask carefully whether there are also spontaneous wheals, they often say, yes, once in a while, once a month or so, I also have spontaneous wheals. And this is important because our current studies either aim for treatment in spontaneous or inducible urticaria. And I think in reality there often is an overlap between the two forms. And as Sabine and Altrichter and Oliver Hausmann already nicely showed, the pathogenesis of urticaria is complex. Several different cell types are involved, like probably the major effector cell is the mast cell, but there are also other cells involved like eosinophils, basophils, neutrophils, and T cells. And that may also depend on the subtype, so whether you have chronic spontaneous or chronic inducible urticaria, or it may even vary between different forms in spontaneous urticaria, whether it's type 1 or type 2 autoimmunity, or I can also imagine it varies whether you have cold urticaria or vibratory urticaria, for example. And I think to a certain degree, your comment, Arthur, was correct, because one can today also summarize all the diseases where these cell types are involved as type 2 diseases. So that would also include allergic diseases, atopic dermatitis, for example, or also people are going into like prurigo or pruritus. I mean, all these diseases probably have a certain overlap that is defined by the cellular infiltrate, and by this cellular infiltrate we can probably also dissect future treatments in more detail. So you already heard about the mast cells. And so the mast cells, for sure, so the classical activation mechanism is via triggering the high-affinity IgE receptor, Fc epsilon, but there are also other receptors that can lead to activation of mast cells. So one receptor, for example, is KIT. So KIT is a growth factor receptor, but is also involved in activation and proliferation, adhesion, migration, and several other functions of mast cells. Or there's also this receptor MRGPRX2 that is probably involved in activation of mast cells, for example, by insect venom, or also by certain drugs. And another receptor that is probably still underestimated today is the complement receptor. Like old knowledge, already like 30, 40 years ago, people knew that anaphylatoxins, so C5a and C3a, are strong activators of mast cells. And maybe in some patients with chronic urticaria, we also have a mix. So the mast cells might be activated via the Fc epsilon receptor, but may also be activated by a combination of like a complement activation plus an IgE activation, or 3 or 4 combinations even. So again, when we look at the interaction of mast cells with these other inflammatory type 2 cells that we see in the infiltrate, there is on the one hand activation of mast cells. So mast cells release a large variety of mediators, so histamine is one, tryptase, and a lot of cytokines, for example, and all these different mediators activate the other cells. And vice versa, these cells, they release mediators, for example, several cytokines that again activate mast cells. So there is a close interaction between these different cell types that may also vary from patient to patient, from stage to stage of the disease, or from subtypes to subtypes of the disease. So that's even more complex. So again, the mast cell in the center, surrounded by other inflammatory cells, and then this complex interplay between the different cell types. And now when we look at the different activation mechanisms on mast cells, we also see how different compounds that are already in clinical use in other diseases or are currently newly developed for mast cell associated diseases can interfere with this activation of mast cells. So here we have the different activation mechanisms of the Fc epsilon receptor, so different antibodies, either IgG, anti-IgE, or IgG, IgM, or TPO antibodies that may all activate in slightly different variations this receptor. But then we have cytokine receptors that can be, for example, triggered by IL-4, IL-13, TSLP, or IL-33. Then we have KIT that is activated by stem cell factor. We have the receptor MRGPRX2 that is activated, for example, by venom insect, but also by certain drugs or antibiotics, for example. Then we have the tryptase antibody receptor, and we have the complement receptors. So this is not a conclusive list of the different activation mechanisms, but is a list of activation mechanisms that are currently explored in the treatment of chronic urticaria. And we already saw this current algorithm in the treatment of chronic spontaneous urticaria. So this is a very detailed mechanism. So here in the third stage, you consider the treatment. So you start out with a single dose of antihistamine. If it's not working, you increase the dose. If that is not working, you go for omalizumab. And if this is not working, then you go for like increasing the dose of omalizumab. And then currently the next step would be cyclosporin. But you all know that cyclosporin, of course, is associated with many different side effects. Such would be other immunosuppressive drugs. Even, for example, rituximab, for example, increases the risk for infection. So it's probably not really a good idea to develop such drugs for a larger number of patients with chronic urticaria. So I think the idea would be to go for something that has few side effects and is still very effective. And I think these new treatments are probably shooting to be established in this phase. So once omalizumab is not working, sufficiently, even though you increase the dose or you shorten the interval between the omalizumab injections, I think in the near future we'll have other drugs before we go for cyclosporine. And like our experience with omalizumab is pretty positive, I would say. So very often we see a rapid improvement. Even though there is no rapid improvement, there are still late responders, such as the type 2 autoimmune patients. Even after 12 weeks, it is estimated that around 10 to 15% of the patients still respond after that time. You have only few non-responders. It's pretty easy to use. We also recently got it for self-injection, and we can train our patients to self-inject, and they really like that. It has very few side effects. In chronic urticaria, there is no anaphylaxis so far, even though it has been reported in asthma. And we can individually dose, we can updose 450 milligram or even 600 milligram, or we can shorten the injection interval. But still, even though we have treated so many patients, thousands, millions of patients in the last years, the mechanism is only partially understood. And one thing I think is really interesting, so even though we have omalizumab around almost 10 years here, and we treat so many patients, it is only approved for chronic spontaneous urticaria. It has never been approved for inducible urticaria. Good example how politics of the companies counteract the need of the patient. And I think you all have the experience that you see a patient with inducible chronic urticaria, and then you immediately think, better I record from the beginning that sometimes there are also spontaneous wheals, because this will give me the option to maybe later introduce omalizumab. So we would really wish to have something for the patients that primarily have inducible chronic urticaria. So now when we look at the different activation mechanisms of mast cells and at the different compounds that are currently developed, there is like a large array of different compounds. They are often also developed in other type 2 diseases, not necessarily in chronic urticaria, but sometimes it also allows to get an idea how it would work in urticaria. And there is a pretty recent list of the therapeutic pipeline in chronic urticaria. So you don't have to understand the full pipeline, so I have to take the glasses to even look more closely at this, but we can go through some of the mechanisms in more detail. So one, for example, is like blocking the IL-1 pathway, of course, in autoimmune disease or more severely affected autoimmune mechanism. Then we have the anti-IgE. So we have the Bruton's tyrosine kinase inhibitors, so the BTK inhibitors, and then we have a series of anti-cytokine or anti-cytokine receptor antibodies that are currently explored. So this is also a pipeline that has been shown for type 2 diseases, and some of them may also work in urticaria. So on the one hand, for example, the anti-TSLP, then we have the anti-IL-13, IL-4 receptor, we have the anti-IgE, we have the BTK inhibitors, also JAK inhibitors can block action of mast cells, and then we have anti-KIT inhibitors. And now let's go through these different mechanisms in more detail. So the idea of the company that produces omalizumab pretty soon was because there were restrictions by a certain license to that didn't allow to further develop omalizumab in other subtypes of chronic urticaria, to develop another anti-IgE antibody, which was ligelizumab. So ligelizumab recognizes a different epitope of the IgE than omalizumab. It has an important overlap in IgE binding with the Fc epsilon receptor, and so it also interacts with open IgE conformation, similar to Fc epsilon receptor. So from the structure and from this mechanism of action, it was assumed that ligelizumab should work very well in chronic urticaria as well. And there was this really well-designed study that compared different dosages of ligelizumab, also with omalizumab and placebo. And the outcome of the study was pretty positive. So here are different readouts, different scores by ligelizumab compared to omalizumab. So you can see over time these different scores that were measured nicely inhibited the activity of the disease, so ligelizumab was quite effective. But maybe, and I don't know all the details about the trials and the politics, but maybe, even though this was, I think, a very good idea to already compare with omalizumab, the established treatment, apparently ligelizumab didn't perform much better than omalizumab, and the company then stopped further development. And ligelizumab is now developed in other diseases like food allergy, for example. Okay, the next group of drugs that I would like to show you in more detail are the BTK inhibitors, so Bruton's tyrosine kinase inhibitors. So Fc epsilon signaling runs through activation of BTK, and these inhibitors aim to inhibit BTK. So signaling of Fc epsilon is blocked by these inhibitors. And in this nice study here from Berlin, different dosages of fenebrutinib, so one example of such a BTK inhibitor, blocked nicely the urticaria activity score 7, and so different dosages were also increasingly effective. So this study showed how well this worked, and even also looked into other cell types and other markers. For example, here the anti-Fc epsilon IgG, and showed that fenebrutinib was also effective in blocking these biomarkers of chronic urticaria. And I know that other companies are at the moment also developing BTK inhibitors in chronic urticaria, so some of the compounds are listed here. And then another drug that is recently more promoted in chronic urticaria is dupilumab, so anti-IL-4, IL-13 antibody that we know very well from the treatment of atopic dermatitis, but also asthma and chronic polyps. And here is a recent paper in the Journal of Allergy Clinical Immunology that combined the results of two studies, so the Cupid study A with the Cupid study B. Each of the study had more than 100 patients, and both studies independently showed a very nice outcome. So here, for example, in the upper line, you see the outcome of the UAS7, and you see a nice decrease in both studies, pretty comparable, that was highly significant. So in patients that do not respond sufficiently to omalizumab, maybe dupilumab in the future might be a good choice. But we, of course, still have to find out in which subpopulation. Here again, the effect of dupilumab in these patients over time. And you can see here, even after the compound was stopped, there was still a nice effect over several weeks, even after stopping the treatment. So then when we go into the different cytokine or cytokine receptor antibodies, I just would like to show you one compound. So one is the KIT inhibitor barzolvolimab, and this antibody leads to depletion of mast cells. So far, the other compounds that blocked mainly the activation of mast cells. But in this study, it was aimed to even decrease the number of mast cells. So if you have less effector cells, then you also have less disease activity. And this study focused on inducible urticaria, so only a small group of patients. Of course, these patients are rare, and this was a type 2 study. So 11 patients with different types of chronic inducible urticaria were treated. And in these patients, for example, in the patients with cold urticaria, this temp test measurement showed how the decrease in mast cells, so the blocking of KIT, improved the score and the tolerance to different temperatures. So in the best response, all of these patients responded. And similarly, in the group of patients with symptomatic dermographism, also all of the patients responded quite nicely. And to control for the effect of barzolvolimab in these patients, the group also investigated the number of mast cells after treatment. And here you can see with an antitryptase antibody in the dermis, in the skin, many mast cells. And after 4 weeks, you already see a sharp decrease in the number of mast cells, and even less mast cells after 12 weeks. And that was also accompanied by other biomarkers such as tryptase, which would also correlate with the number of mast cells. So the decrease or the depletion of mast cells in these diseases apparently is also effective in improving the disease. On the other hand, what this study showed, so if you block KIT, so KIT is not only specific for mast cells, you also have KIT, for example, in stem cells or also in the stem cells of the hair bulb. And if you block KIT, it could, for example, also alter the pigmentation of the skin and the hair. And similarly, like in some patients with barzolvolimab, so they developed white hair. And similarly, also in, for example, in mastocytosis, we use KIT inhibitors. So it's a tyrosine kinase inhibitor that also blocks KIT. And the more the broad you go with these inhibitors, the more you see depigmentation in the patients. Apparently, it's transient, so when you stop the antibody, the pigmentation comes back. Or even in the KIT inhibitors, we observed if you decrease the dose, then you also get some pigment back. So with this, we can conclude that most patients with chronic spontaneous urticaria respond well to omalizumab. Then there is a significant lack of treatment options in chronic inducible urticaria. And there is like a strong therapeutic development that includes anti-cytokine antibodies, BTK inhibitors, and KIT inhibitors. So thank you very much.
So please.
Thank you, Karin. Can we live without mast cells?
Apparently you can. And so that was long not known. So in mice where mice were bred without mast cells, people observed that they get more infections. So then everybody thought, okay, mast cells are important for the defense against infections. But then it turned out that these mouse models were generated in a way that the KIT pathway was blocked. Not only the mast cell, but also, of course, several stem cells that led to a different immune system in the end. And if you selectively block only mast cells in the mouse, then you don't have this increase in infections, as far as we know so far. But different disease models, infection models have been tested, and it hasn't been shown. And in humans, there is no natural mastopenia, so there's nothing known that there is somebody born, for example, without mast cells, so we don't know about it. But we know that patients, for example, with chronic leukemia that get imatinib, like a tyrosine kinase inhibitor over time, like after 1 or 2 years, these patients also don't have any mast cells anymore in the body. So the bone marrow, for example, is really empty of mast cells. And in these patients, we also didn't observe more infections. So apparently, I mean, why do we have mast cells at all? We don't know. So maybe there are subtle stages of infections or certain infections where they are still important, but apparently they are less important than everybody thought in the past years.
Thank you for your interesting exposition. And my question is about the patients, not omalizumab responder, that can improve urticaria after Dupixent, no? And if you have selected different subtype or phenotypes of patients that respond only to Dupixent and not to omalizumab, and your if they have different clinical manifestation, your immunological profile of this patient, please.
Okay, very good point, and I fully agree. Probably the patients that do not respond to omalizumab but would respond to dupilumab are probably different patients. And but I think the details haven't been sought out. But I would say, like, at least here in Switzerland, we have the chance, I mean, we can ask for Kostengutsprache. So before, so we don't have that many non-responders. So in our Urticaria clinic, we have maybe like 10 or 20 patients that we saw as that were really non-responders over the past 1 or 2 years. But in these, I would probably go for dupilumab rather than for cyclosporine. I would really ask the health insurance, and luckily there are a couple of case reports. So there's this Cupid studies that have been reported recently, and I also saw that there's a recent case series from Denmark. So they collected 8 patients and reported that it also worked nicely in these patients. So I think there is more and more evidence that you can use for the Kostengutsprachegesuch.